So in the previous classes, we discussed about general principle of chemotherapy, and then we discussed about breast cancer very specifically. Then followed by that, we have leukemia chapter coming up. But before doing leukemia, this is something very important chapter related to the side effect of the chemotherapy. Because at this time, you have now understanding about all the drugs of cancer. You read in MC also, you read in pharmacology also. You have the grasp of the side effect, and you also read the breast cancer, where we use many kind of regimen, and one of the again common side effect, repeated common side effect you saw was nausea and vomiting. So this has always remained a challenge um, in the chemotherapy actually. Then like nausea and vomiting, this is one of the common side effects, most common, most frequent, and very challenging side effect for chemotherapy. Very challenging, but with the advent of new drug and with the advent of many advanced drugs, we are able to manage it quite effectively in this era. So, can anyone recap quickly why the chemotherapy drug causes nausea and vomiting? Let me see who are there. Aishwarya? Aishwarya, can you quickly brief the mechanism how this chemotherapy drug causes nausea and vomiting?
I don't know, sir.
Okay, we have a detailed mechanism coming up in this presentation, which we will read under the pathophysiology of nausea and vomiting. And I think in your second year community pharmacy as well, nausea, vomiting was one of the chapter. Am I right? Second year
Yes,
community
sir.
pharmacy. Yeah, okay, and I believe some of you might have taken that as a seminar. Is it?
Yes, sir.
So we'll come back to the similar mechanism, but why the chemotherapy causes many side effects is the reason is very simple, as I was telling in the beginning of this chapter, cancer chapter, that it inhibits or it kills the highly proliferating cells, and this mucus of GI, okay, is highly proliferating tissue, highly proliferating cells. And this chemotherapy goes and attack even those cells that irritates the GI and all the GI disturbance, not only nausea and vomiting, even it contributes to the diarrhea. So apart from this mechanism, we have another mechanism how it causes the nausea and vomiting. So we'll see in the coming slide, but let's start with the introduction. So it is often predictable, preventable adverse drug reaction. Okay, so that means when we start with the chemotherapy, we know that the patient is likely to experience nausea or vomiting, and therefore it can be prevented. So many times we give the pre-medication to the patient before giving chemotherapy, and sometimes after the chemotherapy also we dose them with this anti-emetic drug so that they don't feel more nauseated. And all the patient, because this is very common, patient will be knowing that he or she is going to have nausea or vomiting. It's one of the most feared side effects of the chemotherapy treatment. And the problem with this is what will happen ultimately, patient will have low quality of life, and because of that they will try to avoid the treatment. They will not be very compliant to the treatment. They will have some kind of aversion. So attempts to prevent CINV. What is CINV, Bhavit? What is CINV? Betsy?
So chemotherapy-induced nausea and vomiting.
Yes, CINV is our chapter name, chemotherapy-induced nausea, vomiting. Okay. So see, in between, if you don't, if my voice start breaking, if you don't hear me, please interrupt me there. Okay. Because if you are not speaking anything, I'm not very sure. Okay. When my internet gets disconnected or when you are not understanding, you can always raise your hand and ask me anything in between if you have any doubts. So this is chemotherapy-induced nausea vomiting, because this nausea vomiting is because of chemotherapy that you are giving. We have another kind of nausea vomiting like post-operative nausea vomiting. In short, we call them as PO and V. So these post-operative nausea vomiting happens. Why? As the name says, after the surgery, okay, post-operative. After the surgery, the patient will have that wearing of that anesthetics, general anesthetics or local, whatever the patient got it. So that wearing will cause more of nausea and vomiting sensation. But again, when I'm talking this is the treatment of that post-operative nausea vomiting is slightly different from this chemotherapy-induced nausea vomiting. So here our topic is chemotherapy-induced nausea vomiting rather than post-operative nausea vomiting. We have many other type of nausea vomiting, but we will concentrate here only the management of chemotherapy-induced nausea vomiting. So we have, as I told, with the advent of many new therapy and with the advent of many progress in the pharmaceutical science, we have many drugs in the last 15 years that are very effective that patient can tolerate, okay, to minimize the chemotherapy-induced nausea vomiting. So some of the major causes of nausea vomiting, this is in general, okay, these are not very specific to only only chemotherapy. These are all kinds of nausea vomiting, some of the general reason. Okay. Of course, our topic that we are discussing right now is because of cancer chemotherapy. Patient will have nausea or vomiting. Even with the opiates like morphine, okay, patient will have nausea, vomiting, like pethidine, which is a painkiller. Many times, I think you have gone to the ward and you have seen they write pethidine with promethazine. Whenever they write pethidine, they will write promethazine. Have you ever seen pethidine, which is an opioid analgesic? Whenever they write pethidine, they will write promethazine also. They're writing these two combinations together. Have you ever noticed that? No? Yes?
No, sir.
No, sir. So now onwards, whenever you go to any, what you see, whenever they have prescribed this pethidine, which is an opioid analgesic, they will give promethazine also. The purpose is just to prevent the nausea and vomiting because of pethidine. Okay. Started?
Yes.
So I was telling opiates, like these are the analgesic, mostly used as analgesic. Even though those causes now like nicotine therapy, when we give this in rehabilitation, even those patients have nausea, vomiting sensation. Even with the antibiotics, many antibiotics, have GI discomfort kind of symptoms. So they also causes most of the time nausea and vomiting. And the radiotherapy, which is one of the important modality for the treatment of cancer, even this radiotherapy induces most of the time this nausea and vomiting. So these reason, whatever we discussed till now, is because of treatment induced nausea and vomiting or drug related nausea and vomiting. Okay. We have some other kind of reason for nausea and vomiting, like motion sickness. Do you know what is motion sickness?
Yes, sir.
What is that motion sickness, Betsy?
So while traveling, they'll get that sensation of vomiting.
Correct. That there will be many people who while traveling they will get that nauseated and vomiting sensation. So do you know the drug of choice? I think in pharmacology first, it is already written very clearly in the KD3 party. Mahesh, drug of choice for motion sickness, scopolamine. Okay.
Yes, sir.
Scopolamine. Okay. Then we have something called Meniere's diseases. Meniere's disease is vertigo, right? So it's this is related to middle ear. So the patient will have vertigo kind of sensation. Even that can cause vomiting. And the endocrine causes, the nausea, vomiting related to pregnancy. Okay, during the pregnancy time, and the woman will start feeling nauseated or vomiting. So that's the endocrine cause. Some of the infectious causes, of course, gastroenteritis, which whose hallmark symptoms are nausea and vomiting. Similarly, viral labyrinthitis. Labyrinth is the organ of inner ear. There, the inflammation happens because of viral infection, and that can cause nausea and vomiting. Then we have something called increased ICP, intracranial pressure. That can be again because of meningitis or hemorrhage in the brain. So like maybe subarachnoid hemorrhage or any kind of hemorrhage. So even that can cause vomiting sensation. And of course, I was talking about post-operative nausea vomiting. So like maybe because of anesthetics, the patient have been put, or maybe because of analgesic, like I told, opioid analgesic, or if they have done some procedure, even that can cause nausea vomiting. We have some of the Schreiner's curves, like migraine. Many patients who have migraine will have a vomiting sensation. We have something called anticipatory vomiting. That is one of the type of vomiting that I will discuss the types of vomiting here. So anticipatory migraine in many like the aura, when the patient will feel that now he or she is going to get migraine headache. Before that, the patient will start feeling like that, that kind of prescience. Okay, the patient will have prescience that now after half an hour I'm going to get the migraine headache, and as a part of that, he may start feeling nausea, vomiting, or some kind of discomfort. And there is something called bulimia nervosa. Anybody? What is that? Ravi? Bulimia nervosa. This is kind of eating disorder. Okay, when you talk about psychiatric disorder, so this kind of eating disorder related to psychiatric brain. And the patient with bulimia nervosa will eat more. Okay, they won't be having control over themselves while eating. So even such patient will be vomiting too much. So these are some of the causes, okay, major causes of nausea vomiting. But here our discussion is the vomiting related to cancer, the first one, okay, cancer chemotherapy only. Some of the risk factor of chemotherapy-induced nausea vomiting are like patient characteristics, how the patient, some patient may tolerate the chemotherapy very well, some patients may not tolerate, and then chemotherapy specific factor. So it depends on host factors, how well the patient is able to tolerate, and it also depends on the nature of the drug which is being used as chemotherapy. So these two factors are the important factors that is going to decide what would be the intensity of vomiting or nausea that the patient may experience. Some of the patient characteristics are like patient age, whether younger, older, or child, patient gender, whether male or female, then history of motion sickness, had patient previous history of any motion sickness, traveling related nausea, vomiting, or any morning sickness during pregnancy, or had any prior history of nausea, vomiting because of chemotherapy, or the patient have any history of anxiousness. Many patients, because of anxiousness, will have nausea, vomiting, and some patients will have inadequate hydration. I request those whose background is noisy can mute yourself. Well, if you have any question, then you can unmute, raise your hand and mute yourself. I think it's Suparna. Suparna, can you please mute yourself? Or are you asking me any question? Can everyone hear me?
Yes, sir.
Yes, sir.
Can hear me? Okay.
Yes, sir.
Okay, fine. I thought maybe she's trying to ask me some question and I'm not able to hear her. Okay. Everything is smooth, right? You can hear me quite well. Okay.
Yes, sir.
So sometimes this anxiety, okay, anxiety can also induce vomiting and nausea, and sometimes this inadequate hydration. If the patient is not hydrated well, they can have this nausea sensation. Now coming to, these were the patient specific factor. Now coming to the chemotherapy specific factor, that is the drugs that you are using. Here we use the word amitogenicity. Okay, so amitogenicity is a word that we use to attribute on the ability of chemotherapy to induce nausea, vomiting. If it is highly amitogenicity, that means it can it may have high tendency to cause vomiting. If it is less amitogenicity, it have less ability to cause nausea, vomiting. So amitogenic potential of a chemotherapy agent is very important factor to tell that, or to declare, or to estimate how to what extent the patient may experience the nausea, vomiting. And then short infusion time. If the drug is like most of the chemotherapy, when you see, they will have long infusion time. Okay, they will dilute the drug and then they will infuse over a long period of time just to make the patient tolerate it better. But some drug which are infused for a very short period of time, they have like high amitogenicity. They have they can induce nausea vomiting to a high level. Then repeated cycle of chemotherapy. If the cycle of chemotherapy is very repeatedly, it have high emetogenicity again. So I was talking about emetogenicity potential of chemotherapeutic agent. Emetogenicity is one of the important factor to estimate how to what extent the patient is gonna feel nausea vomiting. So let us look at the drug, some of the drugs, and their emetogenic potential, like to what extent what drug causes the nausea vomiting. So we have categorized the emetogenicity of all the drugs under several categories, like high risk emetogenicity, moderate risk, low risk, and minimal risk. Okay, under these 4 criteria, we are going to categorize most of the drug. For example, high risks are those class of drugs which have the emetogenicity potential of greater than 90%. Okay, moderate risks are which have the emetogenicity potential of 30 to 90%. Low risk are 10% to 30%, and minimal risks are less than 10%. Clear?
Yes, sir.
Am I understandable?
Right.
Okay. Now we'll see what are the list of drug under high risk. Okay, we have cisplatin. If you use cisplatin, this you should keep in mind that these are high risk emetogenicity. That means patient is going to get more likely to nausea and vomiting sensation. Similarly, if you use carmustine at the dose greater than 250 milligram per meter square, then there is high chance of getting like there is greater than 90% chance of patient feeling nausea vomiting. But remember, you can see the carmustine even in moderate risk column. You can see if you use the carmustine if at less than 250 milligram per meter square, then it's not high risk, it's moderate risk. Risk is at and the risk decreases to 30 to 90%, but not more than 90%. But if you are using the same carmustine at greater than 250 milligram per meter square, that means the risk is greater than 90%. Okay, so it also depends. That means it also depends on dose at what we are using, as I was telling. So similarly, we have lomustine being used at greater than 60 milligram per meter square. That's a high risk. We have dicarbazine. If you are using at greater than 500 milligram per meter square, that's a high risk category. Then meclorithamine. If you are using meclorithamine, then again there is high risk of getting nausea and vomiting. Then you have pentostatin. Okay, pentostatin, then that's again high risk drug. Then you have streptozocin, that's again high risk. Then dactinomycin as well. In the moderate risk, you can see cyclophosphamide. If you are using at less than 100 milligram per meter square, that's a moderate risk. But if you are using cyclophosphamide at greater than 1,000 or 1 gram per meter square, what is that? Aishwarya, if you are using cyclophosphamide greater than 1 gram per meter square, that's a high risk or moderate risk?
High risk.
Yes, high risk. If you are using more than 1 gram per meter square, that's a high risk. If you are using less than 1 gram per meter square, that's moderate risk. Even the anthracycline, carboplatin, citarabine, 1 milligram per meter square, irinotecan, mifelin, okay, metogendron, oxyplatin, oxaliplatin. So these are moderate risk, okay. Whereas at if you see low and minimal risk for the methotrexate, if you are using methotrexate at 100 milligram per meter square, that's a low risk, 10 to 30%. But if you are using the same methotrexate at less than 100 milligram per meter square, that is having minimal risk. Okay, so these are the just to look at the risk, how much risk is associated with what drug for nausea and vomiting. This is something very similar to what we saw in the previous slide. This is again the way of categorizing. Here it is categorizing 5 category based on again incidence of MSS. So level 1, it is called Hesketh level 1. If it is Hesketh level 1, that means the incidence of MSS is greater than 90%. If it is Hesketh level 5, that means incidence of MSS is less than 10%. It is same concept, same thing, just the difference in name and the scientists who categorize it. Okay, but this grading is different, okay, than what you saw here for high, moderate, low, and minimal. Okay, there is 4, but here is 5 category or 5 class. So now coming to the types of chemotherapy induced nausea vomiting. Okay, what are the types of nausea vomiting that you will see in the chemotherapy? The first type is called acute. As the name says, it occurs in the first 24 hours of chemotherapy administration. The next type is delayed, which occur 24 after the chemotherapy administration. Okay, after the 24 hours of chemotherapy administration, the patient will have this kind of nausea, vomiting. The third one is anticipatory. Okay, as the name says, you anticipate this kind of nausea, vomiting. That means this occurs before starting like conditioned response. For this kind of conditioned response occurs before starting a new chemotherapy cycle in patients who have experienced uncontrolled nausea, vomiting with prior treatment. So you anticipate because you have the information that in the previous cycle the patient had excessive nausea, vomiting. So you anticipate in this cycle also the patient is going to have extreme nausea, vomiting. So based on that, you treat. Sometimes you give the pre-treatment. Sometimes they will give the antiemetic before giving the chemotherapy. Okay, then the fourth one, we have a breakthrough chemotherapy-induced nausea, vomiting. Here they will give a preventive therapy to prevent the nausea, vomiting. But despite that, the patient will have nausea. This is breakthrough nausea, vomiting. And this breakthrough with nausea, vomiting, and the last one, refractory in nausea, vomiting. These are very closely related, but there is distinct different. You can figure it out. This refractory is as the name says, refractory means this is not responding to some treatment maybe. So the breakthrough you saw, you gave a treatment, but still the patient had nausea, vomiting. In refractory, the nausea, vomiting occurred even after the preventive treatment. So this point is similar to the breakthrough, but here in refractory we consider those patients who like even in the subsequent treatment, in the treatment gets failed. Okay, even in the subsequent treatment and subsequent cycle, they are not responding like breakthrough. Okay, so this refractory is from cycle to cycle, whereas breakthrough is for one particular cycle. So now coming to pathophysiology of the nausea, vomiting. Can you see this slide? Is it legible?
Yes, sir.
Yes,
You
sir.
can pinch out. You can pinch out to zoom in. Is it legible clearly? You can read
Yes,
out the
sir.
slide.
Yes, sir.
Okay. So this is the pathophysiology of nausea, vomiting. How the nausea, vomiting happens. This is what you might have read in your second year community pharmacy as well. So we have at the higher cortex region, we have the all the information goes in the cortex region, from the sensory neuron, and then there we have the sensory region where we sense everything. Similarly, we have for the vomiting and nausea. Okay, so this from this cortex sensation, from this cortex region, we have the region like memory, fear, anticipation. Okay, we have the sensory region of pain, smell, sight, right? All these sensory, whatever information goes through eye, skins, taste, all this goes into particular region of sensory cortex, and there we perceive. So sometimes in the pathophysiology of vomiting, one thing you have to remember is vomiting center. Okay, in the medulla oblongata, which is a part of midbrain down the brain. So there we have a vomiting center in the medulla. Okay, so all these vomiting reflex happens because most, not all, we see there are some other like from stomach and chemotrigger zone, labyrinth. So from all these places, the information goes into this medulla, which is a vomiting center. Where is the vomiting center? And then vomiting reflex starts. Okay. So in all this pathophysiology, we are going to see that all the information from wherever it is coming finally to the vomiting center, that is medulla. That is at the medulla, and then the vomiting reflex starts. So we are now in the process of discussing first input that come to the medulla from cortex. Okay, from higher cortical centers. So here, the information went through smell. The sensory information can be smell and sight. You saw something, you smelled something. Sometimes even that can trigger nausea and vomiting. You know that if it is very foul, smelly, that can cause you to vomit. So sometimes the memory, okay, the memory, the fear, the anticipation, this is what I was talking about, anxiety, okay. This even itself can provoke the vomiting. Do you agree? Have you experienced ever?
Yes, sir.
The memory, the fear, and this is the reason actually you see before surgery, many patients are put on the benzodiazepine. They will give some diazepine or something like that. They'll put the patient on alprazolam or something like that before surgery. Okay, they just want to calm their system and so that they don't become anxious and the circulation gets lower. So so here the treatment modality, because the patient is anxious, have fear, and you can therefore you can use this benzodiazepine to treat the vomiting because of this thing, because of this reason. So basically, you should know what is the reason for vomiting, and based on that, you can give the treatment. So if the vomiting is because of fear, memory, anticipation, that is from the sensory cortex region, you can give them benzodiazepine. Clear? This one is clear?
Yes, sir.
Okay. Let's come to the chemoreceptor trigger zone. Okay. In the fourth ventricle. So if I'm talking about fourth ventricle, I'm talking about heart, isn't it? Isn't it?
Yes, sir.
Bhavit?
No, sir.
No, sir.
No, sir.
Swastika, I'm talking about heart, fourth ventricle, isn't it?
Yes.
Dipti?
No, sir.
They aren't there. Then what I'm talking about?
Brain.
Brain. Okay, brain. So we have fourth ventricle in the area proxima region. Okay, where there is some area proxima is only zone in the central nervous system where there is some kind of leakage, or where there is the region where sampling can be taken from blood to the brain. Okay, so this is you can say this is because our brain needs some kind of sample from the blood so many times. Because of that, this reason is there, and it have many other function. Okay, so this area proxima at the fourth ventricle, we have chemo trigger receptor zone. Okay, also called as in short CTZ. So if this gets irritated, if there is any stimuli which can stimulate this, the information can go to the vomiting center, which is in medulla again. So how this gets stimulated, maybe because of opiates, as I was telling, pethidine, that can stimulate the CTZ, maybe because of anesthetics, or maybe because of even chemotherapy. So these things can trigger the chemoreceptor trigger zone. That's why we call chemoreceptor, because the purpose of this receptor is to sense the chemical. Okay. So because of that, the patient can have nausea, vomiting, and one of the way to treat such nausea, vomiting is you give histamine antagonist. Histamine antagonist. This is what I was talking. Promethazine, and I told promethazine, right? Along with pethidine, they give promethazine, right? So
Yes.
you can give the promethazine, muscarinic antagonist, dopamine antagonist, or cannabinoids. So these are the treatment modalities for treating this kind of nausea, vomiting. Okay, so now coming to the another type of impulse, you have from stomach. Okay, stomach or small intestine. From stomach, like whatever you eat, those things can go and trigger the chemoreceptor trigger zone, or this can directly also stimulates the medulla if the like getting absorbed into blood and then going into the medulla. So for example, some of the radiotherapy, maybe also surgery, and then chemotherapy. So these things can cause vomiting. Okay, and to treat these, we can use many treatments like 5-HT3 antagonist. Okay, you can use many kind of prokinetic, gastroprokinetic acid like metoclopramide. We can use sphincter modulators. Okay, so if we know, okay, the nausea, vomiting is happening because of this, then labyrinths. I was talking in the ear, we have labyrinths. If there is any kind of surgery related to ear which have affected the labyrinth, that can cause vertigo. Okay, so for and vertigo and cause nausea, vomiting. So for that, we can use histamine antagonist or muscarine antagonist. Histamine like betahistine. Have you heard of this drug, betahistine? In BBS, I think Vertin is the brand name. Have you heard of that?
No, sir.
Okay, so that a drug which can be used for the nausea vomiting that happens because of this labyrinth issue. This is the same picture, okay, what we discussed in the last slide. The same to same, nothing different. Only the way of representation is different. Okay, the same thing. Okay, nothing much to tell you. I told you vomiting center we can use 5-HT3 receptor antagonist, we can use NK1 receptor antagonist, we can use dopamine receptor antagonist, because in vomiting center we have these 3 receptors. Okay, so in chemotrigger zone again we can use the same 3 antagonists, and gastrointestinal tract you are seeing of those intrachromatin cells and those serotonin release 5-HT3 receptors, so we can block all those receptors and then treat the vomiting. Chemotherapy, cancer therapy induced nausea vomiting. Is this clear to everyone?
Yes, sir.
Is this
Yes,
clear to
sir.
everyone this much? Okay, how much
Yes.
time we
Yes,
have
sir.
left for this meeting? It is showing in your screen.
1 minute.
1 minute only. So if we get disconnected, please join through the same link. Okay, we'll wind up this today. Now only treatment part is remaining. Okay,
Less
now
than-
moving towards the consequence. Pardon?
Less than 1 minute.
Less than 1 minute.
Yes, sir. Remaining time.
So it won't get upgraded on its own. It won't get upgraded on its own, or we have to rejoin again.
Rejoin again, sir.
Okay, so in the last class, what and all we discussed? Can you summarize, Julissa, quickly?
So we discussed about the its introduction of chemotherapy-induced nausea and vomiting, then its risk
Okay.
factor, its pathophysiology, and its type.
Yeah. And what are the factors that can affect patient characteristics and the chemotherapeutic characteristics that governs the emetogenicity? Okay.
Yes.
Emetogenicity of all the most of the drugs we saw. So now in this class we are going to discuss the consequences of nausea vomiting. What happens? Okay, we are telling nausea vomiting we need to prevent. These are the emetogenicity, these are the pathogen, these are the risk factors, these are the etiologies. But what will happen because of nausea vomiting? That we'll see. Okay. What will happen? The patient will get dehydrated very heavily. Because of that, the patient can have electrolyte disturbance, and therefore patient can have many heart complication or any kind of kidney diseases because of electrolyte disturbance. Patient can have aspiration pneumonia. Do you know what is aspiration pneumonia, Julissa?
Difficulty in breathing.
Mahesh? Aishwarya?
Yes, sir.
Aishwarya?
No, sir.
Betsy? What is aspiration pneumonia? I'm asking. Aspiration pneumonia is, you know what is pneumonia? Okay, that when the aspiration pneumonia happens, for example, when the patient, like many patients who are in STU or ICU who cannot eat the food like very well, whose esophagus is not that well trained. What happens is when you give them the food with the mouth, there is high chance that the food can go into the lungs. How food can go into the lungs, Mahesh?
Sir, that foot pipe and windpipe are closed. That epiglottis will be there, no, sir.
Yeah, correct. So that epiglottis, they don't have that control of that epiglottis. This is the reason. This is one of the reason you see many patients in ICU, STU, they put them on nil per oral. They don't give them orally because there is high chance that the material, the food particle can go into the lungs, and that can cause infection in the lungs or pneumonia. So this type of pneumonia is called aspiration pneumonia. So if the patient vomit, and this is one of the reason we don't want the patient vomit who are in ICU or HICU setup, because once they vomit, there is high chance that vomited particle can enter the lungs. Okay, so this type of pneumonia is called aspiration pneumonia. Am I clear to all?
Yes, sir.
Okay, so this is one of the complications of nausea vomiting, isn't it? Because of that nausea vomiting, this aspiration pneumonia has happened. And then this of course can cause malnutrition and weight loss, and this also can delays in cancer therapy, which is very much essential required requirement for the cancer patient. It can also impact the quality of life. It causes distress, anxiety, and fear. There is negative effect on the patient's daily activities. That means it lowers down the quality of life. Patient, as I was telling, sometimes back in the presentation, patient will have refusal to treatment, or they may not comply with the cancer therapy. They will have maybe some degree of aversion to take the anti-cancer drug. And of course, the patient will have economic burden because of increased medical care by repeated hospital admission, and there will be increased use of, again, and many kind of anti-emetic drugs. Some of them are these are not that expensive, but again, some of them, the new drug like Epipriptan, they are coming as expensive. So this also can, one of the consequences can also be economic burden. Okay, now we'll see the management of chemotherapy-induced nausea vomiting, how you can treat this. We have non-pharmacological management. You can advise the patient not to wear the tight fitting clothes, because that can again make the patient feel uncomfortable and vomit. So wear loose fitting clothes, and rather than eating one time in a huge amount, suggest them to split their meals in a small portion, but they can, and let them take frequent meals. Okay, eat small but frequently. Then avoid certain foods like sweet, fatty foods, which are in high salty food, some of the spicy foods, and food that have very unpleasant kind of odor. Okay, if they are feeling unpleasant, if they avoid such food, then that can decrease the chances of vomiting or nausea. Then maintain a relaxed atmosphere. Sometimes many people will get the feeling of nausea, vomiting when they are in crowded atmosphere. Okay, so maintain a relaxed atmosphere. Then consult a dietitian to assess proper foods, portion and texture, what they should eat. The dietitian can give a better specialized opinion. Then try some complementary therapy like relaxation, hypnosis, yoga, meditation. That can help them to calm down their anxiety. And then these are some of the non-pharmacological approach to treat the nausea, vomiting because of chemotherapy. Some of the pharmacological management we will discuss here. So these are the modalities that we can use for treating the nausea, vomiting, chemotherapy-induced nausea, vomiting. Now here comes the importance of recalling back that pathophysiology diagram. If you remember what receptor were there. So if you are able to remember that receptor, we'll use exactly the drug that can block those receptors and can reduce the sensation of nausea, vomiting. Okay, so we have some of the prokinetic agents. These are just the class of drugs. Okay, we'll also see some of the specific drugs under each class. These are some general class of drugs. We have prokinetic agents. We have phenothiazines. We have butyrophenones. We have benzodiazepines. We have cannabinoids. We have serotonin antagonists. We have NK1 receptor antagonists, and we have corticosteroids. So we'll see all these one by one. Let us see. So before we see that the one by one drug, so this is a graph. Can you see? Is it? I think this is not coming clearly in my screen. Okay, now is it okay? I think. Can you see this graph in your screen?
Yes, sir.
Yes, sir.
What is in the x-axis? What you can see in the x-axis?
Only half it's coming, sir. Half.
Yeah, that's what I was telling. So I will send you this PPT in your WhatsApp. I think I have sent already. So
Yes.
you download in your system, and then there you can see in x-axis we have here the timeline. Okay, from 1990s to like 2000, the development of several kind of drugs. So whatever classes of drugs we discussed in the last slide, same class of drugs, but what year it came, what decade it came. That's what this graph depicts. Okay, for example, phenothiazine came first, and followed by that dexamethasone, serotonin antagonist, and then 5-HT3 antagonist, like that. Okay, then now recently and Epipriptan and all this. So let us see one by one of each class, one example, and then the drug. prokinetic agent. Okay, metoclopramide. We are very much familiar with this drug. This is a prokinetic agent, and this have two mechanisms. Actually three. Okay, this act in two receptor and also alters the gut movement. Okay, so this act at low dose this act on D2 receptor, and at high dose it act on ST3 receptor. So this can block to both the receptor, D2 receptor and ST3 receptor. And because of blocking of this D2 receptor, the patient have the side effect like related to extrapyramidal symptoms like akathisia, echinacea, all those things. Then ST3 receptor antagonist, like the way our ondansetron work. So metoclopramide that is why metoclopramide is a good drug for nausea vomiting. So then the dose is 10 to 20 milligram per oral or IV you can give. You can combine this drug with dexamethasone, and then first line prophylaxis. When you combine this dexamethasone, it becomes first line prophylaxis for acute chemotherapy-induced nausea vomiting. And then you can use this in breakthrough CIND as a first line with or without dexamethasone. Coming to next class of drug, which is phenothiazine. These act on H1 receptors and D2 receptors. The drugs are prochlorperazine, chlorperazine, and promethazine. Okay, this is what I was telling. With pethidine, they give this promethazine, which is a phenothiazine class. So this is a kind of older drug, but still very effective. They work very effectively in controlling the nausea vomiting. The dose are 10 mg per oral or per IV for prochlorperazine. Chlorpromazine, the dose is 25 to 50 milligram per oral. For promethazine, 25 milligram per oral, or sometimes 50 milligram per oral. This is again can be used with dexamethasone as a first line prophylaxis for neoplastic agent. With those neoplastic agents which have mild to moderate emetic potential, and I discussed already what is that mild to moderate emetic potential. Then third class of drug we have butyrophenol. The example is haloperidol. This is a D2 receptor antagonist like metoclopramide we saw, but these have stronger potential, stronger affinity to G2 receptor only. The dose is 0.5 to 2 milligram per oral or intramuscularly, and this can be used as a first-line therapy in breakthrough nausea vomiting. We have the fourth class of drug, benzodiazepine. The example is you can say many example of this class. Can you give some example? But also remember this benzodiazepine have many other action also. If you remember, these have anti-epileptic action, these have anti-anxiety action, these have sometimes analgesic action. These are also used sometimes as I told you anxiolytic, and then sleeping aids. These are sometimes some of the benzodiazepine are used as anesthetics, local anesthetics. So there is wide diverse use of these benzodiazepine, and one of them is as anti-emetic. So lorazepam, this reduce the anticipatory anxiety and calm the centers that can directly stimulate the vomiting center. That's what we saw in the pathophysiology slide. The dose is 0.5 to 1 milligram per oral before the chemotherapy, so that the patient will be calmed down and the patient will not feel nausea vomiting. So this can be used for breakthrough chemotherapy-induced nausea vomiting. The fifth class of drug, cannabinoids. Okay, the drugs are dronabinol and nabilon. Again, these drugs, because these are cannabinoid derivatives, these are like very like they have many side effects. And if you see the site of action, there are some of the receptors which act, but it's not again very clearly clear. They say cannabinoid receptor, okay, and the mechanism is not very clearly clear over there. Again, it can be used in refractory breakthrough chemotherapy-induced nausea vomiting. And you all know 5-HT3 receptor antagonist, ondansetron, one of the most commonly used drug. So this 5-HT3 receptor acts in GI mucosa and CTZ. We have these receptors. These receptors gets blocked by this drug, and then the nausea vomiting gets decreased. The drugs are ondansetron, which can be used at 8 mg per oral IV, or granisetron or dolasetron. Okay, these are the same class, but different potency and different characteristics. This can be used as first-line prophylaxis for delayed onset chemotherapy-induced nausea vomiting. If you remember, we had acute onset and delayed onset. And this can be also used for acute and breakthrough chemotherapy-induced nausea. We have the 7th class of drug, which is neurokinin 1 receptor antagonist. The drug is aprepitant. Okay, this is the newer drug, like a little bit more efficacious and potent in controlling the nausea vomiting. There are substance P or this neurokinin 1 receptor in the GI tract and in the brain. So these drugs goes and block those receptors. Okay, and this is how it acts. This can be also used in combination with 5-HT3 antagonists like ondansetron and with dexamethasone. Then the 8th category of drug, corticosteroid, can be used as used as a first-line prophylaxis for chemotherapy-induced nausea vomiting. In those chemotherapy-treated patients which are like mild to moderate emetogenic potential, but the exact mechanism how it controls the nausea vomiting is not very much well known with the steroids. But this dexamethasone do work very well in the chemo patient. Most of the time you go in the ward, you will see the patient on this dexamethasone. This is used in combination therapy with prochlorperazine as a first line for acute CINV, and then also serotonin receptor antagonist as a first line for delayed onset chemotherapy-induced nausea vomiting. So these were the treatment modalities that we have. Again, you can compare the advantage and disadvantage between each treatment, each way of treating. And remember, if you are very much thorough with the pathophysiology slide that I showed you, you know what are the receptors, what are the way to get the patient nausea vomiting. And if you remember that, you just put the drug at different steps, and you can remember all the drugs that are used in the management of chemotherapy nausea vomiting without missing any of them. So prevention of emesis, how will you prevent? Most of the time, you have to give the drug. We have to give the this antiemetic drug before starting the chemotherapy. Okay, so if you are using high level emetogenic antineoplastic drug, so you start the aprepitant 125 milligram per oral on day 1, and then 80 milligram per oral on day 2 to 3. Okay, and dexamethasone 12 milligram per oral or IV on day 1, then 8 milligram per oral on IV or IV daily at 2 to 4 daily days 2 to 4, and then 5-HT3 antagonist, maybe ondansetron, granisetron, or dolastrone, or palanestrone, with or without lorazepam. So because these are high emetogenic antineoplastic drugs, so you are combining many drugs before starting the chemotherapy. If you see the moderate emetic risk chemotherapy, we are not using that all those drugs. We are using some less drug like dexamethasone as HT3 antagonist. This is the two combination. So instead of HT3 antagonist, again, sometimes you may have to combine with lorazepam or not. So depends on which level of this thing you are using. Okay. So then conclusion is that prevention is better than treatment. If you give the pre-treatment to the patient for preventing nausea vomiting, that's easier way to manage than giving the anti-cancer drug and then treating if the patient reports the nausea vomiting. So assess the risk factor, as we saw in the beginning of the presentation. What are the risk factors for patient to get nausea vomiting, whether it is related to patient or whether it is related to treatment. So if you know that, you can manage it better way. And then guidelines should be there for each hospital for management of nausea vomiting, chemotherapy-induced nausea vomiting. As you know, for each hospital we have the antibiotic policies similar like that. We should also have this and chemotherapy-induced nausea vomiting management guideline. Then we should follow the evidence-based guidelines, evidence-based medicine, which will help to prevent and treat the chemotherapy-induced nausea vomiting in a better way. Okay, so you can go through the DPRO, okay, which will give you better insight. You can also refer Roger Walker. Okay, so these are the references used here. Something from Sarger also. So if you have any question, you can ask from this chapter, chemotherapy-induced nausea. With this, now we have only one chapter remaining in cancer, that is leukemia. Am I right?
Yes, sir.
Yes, sir.
Yes, sir.
So